Joe, on behalf of you and Mohammed Mackey and the whole NAS Oncology group, including the Seattle Science Foundation, Icotech, I just want to thank everyone for showing up to this. So what we've done to this point, just to kind of touch on some things, is Joe Schwab and his team from actually multiple sites, not only from his previous place at Harvard, but his new place in LA, had a discussion. And then Mohammed Mackey had a discussion, a debate from some of his colleagues at Cleveland Clinic. And so in the spirit of that, we are now having a discussion with our team at Northwell Health, which is in New York. And today I'm going to introduce Dr. Larry Lowe and Dr. Aladdin El-Samadisi, who are both spinal oncology surgeons, to really talk about what it makes the best spinal oncology care for patients based on clinical and research. And so I'll start with Dr. Lowe, and let me just introduce Dr. Lowe. So he's a neurosurgeon by training, who has dealt with spinal oncology for years. And Larry, I know you run multidisciplinary rounds. I know you publish a lot. But for you, where we're going to start is, clinically speaking, for all those people out there who say they take care of patients with spine tumors, what do you feel is the current state of the art to be a really good spinal oncologist for our patients? What factors are important if people are taking care of these patients clinically? And then we'll go on from that. I want to get your thoughts on it, given your experience.
Thanks for the introduction, Dan. So I think by far the most important thing is that as surgeons, we don't work in isolation, especially for spine cancer care. I think that the ability to perform the surgery and get the patient safely out of the operating room and out of the perioperative recovery period is really just a starting point. I do think that all of the sort of clinical decision-making is made beforehand in a multidisciplinary setting. So I do think that in terms of a modern spinal oncologist, the ability to work with medical oncology, radiation oncology, pain management, our orthopedic colleagues for more complex surgical cases, surgeons from other specialties, as well as even palliative medicine. I think all that's critical to caring for metastatic spine disease and primary spine cancers these days.
So that serves me. Then I'm a spine surgeon or a neurosurgeon or orthopedic surgeon, and I get called with a complex patient. What are the steps I'm doing? I'm not taking that patient in the operating room? Am I asking for help from people? Am I convening them emergently? Am I doing this? What is the aspect of this? Because I feel like this is something that we're often challenged by, where people will call me and say, I took care of this patient, I wish I did it differently, or I should have thought about this. So what are the things that you've learned, maybe the good and the bad, over the last few years, in terms of the best way to manage a patient who gets either dropped in your clinic, dropped in the ER, and maybe they're different, but what were some of the essentials that people have to have in order to take care of these patients ideally?
I think the gut reaction when we see somebody in our clinic or in the emergency room as a consult with high-grade spinal cord or cardiac compression is that I feel like as surgeons, we are wired to offer that patient surgery right away. But I would say most often from what I've learned is that obviously you do have the patient population acutely decline, that where truly hours makes a difference. But for the most part, especially in the setting of a slowly growing tumor, or even if it's aggressive, the patient's probably presenting with some relatively mild neurological deficits, and you do have a window to either consult with your colleagues at your institution or even reach out to the primary oncologist for that patient. I think it's a little bit trickier if it's a new diagnosis of metastatic spine disease or if it's a primary tumor that's unknown. But I do think that we've more or less shied away from, even in an acute setting of somebody presenting with a neurological deficit, for the surgeon to unilaterally make a decision about surgery, but rather at least quickly convene on a sort of ad hoc basis of a quick tumor board discussion to at least rope in the key players, such as the medical and the radiation oncologist, to figure out what makes the most sense. Because, like I said, I feel like as surgeons, we are very ill-equipped to understand exactly what the systemic options are for the patient, as well as the anticipated prognosis.
So one thing I've heard, as you know, I dealt with creating a tumor board back in Baltimore when I was there, and you've led it at Northwell. How do you get these different people with different schedules and different demands on their time, and maybe different resources, to be able to come together? Because I often hear also that when people say, hey, you know, at our center, we're trying to have a really a really involved, engaged, multi-D spine and tumor board because that's apparently the way to do it. But it's just hard. I got someone sees I just got to see a patient, then I got to call somebody. I don't even know if I know these people. What is your advice in terms of beginning this? Because you've created this here at Northwell, and we're part of it at Hopkins with me. But and this system's even much bigger than Baltimore. So tell me what you think is essential in those teams.
I mean, basically, I took your advice, which is I do think that the meeting has to make sense for everyone, right? So, not to sort of downplay the education side, but I do think that the fact that it's a working meeting where we are respectful for everybody's time is quite good. We spend very little time on the education side because there's opportunities for that for our fellows and residents, but really, we try to keep it under 30 minutes weekly. We try to stay on schedule and we try to make sure that everyone's roped in, right? Like I said, I think one of the things that comes to mind is that I think that, for example, if you're a medical oncologist, you might be fearful that a conference that's potentially driven by a surgeon might decide that everybody gets surgery, right? Whereas we want to make it clear that we are truly trying to come up with the best plan for that patient, even if it's palliative care, right? And I think that other surgeons sometimes might not feel comfortable sort of bringing their cases to a bunch of strangers and discussing it, but I do think sort of this non-threatening collegial environment is critical to the success of a multi-D board. I think that making it efficient so that it's not wasting anybody's time, truly trying to be mindful of everybody's time, right? We, as you know, when we run our conference, we truly try to make it like, what is the question that is trying to be answered? And we answer that question quickly and then we move on. And I think that that's probably something where if the meeting brings value to all the different specialists, then I think that that's how we get engagement from all these different specialties.
So I have one more question on this before we start including Ladin here. So I can imagine also that in your mind, you might have seen a lot of patterns and you can say, I've seen this before. And then you also have colleagues that you know that you can call on. But as we all are part of systems that are bigger than just ourselves, in other words, we're not just managing our own practice. Your thoughts and opinions are going to impact other people's practices, and there's yours. And we all are part of health systems. So one thing I struggle with is as we get bigger, and any part of the cell system, someone could enter with a spine tumor. They can enter it through the medical oncologist. They can enter it through a radiation oncologist. They can enter it through a surgeon's office, ER, a phone call, what have you. How do you deal with keeping some, I would say, some quality control or some ability to learn from these when sometimes you feel like the system is very big? And for example, I'll just say, Northwell is the largest cancer provider in the New York metro area. And we have places from Jersey to Connecticut to Manhattan to Long Island. And, you're just one person and you have some thoughts, but how do we have it as a bigger team that we know that wherever someone enters our health system or our clinics, that they're going to get the same quality that you would provide at your best, or that maybe you're not at your best and you need some other opinion from someone off elsewhere in the health system. How do you see this coming together in the best possible light so that we give all patients really the best care that they can get if, wherever they enter?
I think that obviously for a system like ours, where there's so many points of entries into our cancer care, I think it's obviously very, very difficult. But one thing that we've been doing is sort of purposefully growing and essentially having somebody that we trust at each of these areas. I do think that the key here is not only sort of are we sort of the mothership in the center in terms of any more of the complex cases can easily be presented to us, but we also know that out in our network for all these sort of newer recruits that we have somebody that we've either trained or we know who trained them. We know that they're trustworthy, and we know that if there was something that they had a question about, they could always reach out to any of us. And I think that that sort of more deliberate mindset of growing and sort of to get people that we trust in each of these hospitals, I think it's key.
Yeah, it's definitely a challenge as we all continue. I always say that they always want Big Macs to have the same quality control in LA that they are in Miami. And sometimes McDonald's probably is challenged by being stretched. And I feel like we do that as well. When everyone's in this room, just like we're having now, we can all agree on things. It's sometimes getting people in the room and they're in different places, different times.
Absolutely.
So, one thing I want to switch a little to Aladdin. Aladdin, one thing that we kind of brought up with Dr. Lowe is, what creates a lot of us think of as the cutting edge or best in class spinal oncology care now. And Larry talked about including people with expertise and basically creating teams. But as you know, Aladdin, and as a great researcher who's written many, many papers on the subject and many grants, we have so many unanswered questions. So, what is your take on where spinal oncology should be going and how do we get there? And what are some of the factors that you think are important to answering questions that we still struggle with? In other words, what is the research component that needs to make it so that next year we're even better than we were this year? And what are some of the factors that are part of your plan for that? In other words, not just saying do work hard and do your best. What are some of the factors you think are important to create good research moving forward in spinal oncology?
Thank you, Dr. Shuba. Um, so I think with research in spinal oncology, there are multiple facets similar to what Dr. Lowe was doing and talking about in terms of how does a multidisciplinary team work together to provide the best plan of care for a spinal oncology patient. I kind of think of the same way for the research aspect is that there are so many different aspects to a patient's care that we still don't have the full answers to. So, for example, we as surgeons, we look at, can a patient come on and off the table safely? Can they make it to clinic? Can we get them the care that they need? But then other aspects, you talk to a physical therapist, well, because of their malnutrition or their deconditioning, their physical aspects have been limited. And then you speak to a nutritionist and you talk about their malnutrition and their strength and so forth. And I think with spinal oncology research, it's not the same dogma of how we look at surgical patients, similar to what we do with like spine patients, deformity patients, degen. But how do we then incorporate both frailty and other components that can allow for better care? So some of the things that we've been working on uh, is can we, for instance, identify what, which is a blood test and so forth, can we correlate that with the intrinsic class and osteoblasts for the bone turnover markers? Can we fully understand how a fusion can happen and help a patient? And so I think with spine tumors, there's a lot of different components that go into it. But I do think frailty and the physical ability to withstand this acute stress of surgery is going to allow for us to do better care and get the patients the care that they need post-operatively.
So, I hear a lot about this frailty, and I think it's kind of one of those things that we all know it when we see it. But there's a lot of gray area in terms of our ability to predict if patients are going to do well or not. And then telling the patient, we're going to go super aggressive because you can handle it, or we're going to go not aggressive because you can't handle it. It seems arbitrary. Do you see research in the future giving us some objective scoring that you think could be predictive? And so maybe this is wrong, but and you don't have to answer this in yes or no, but obviously expand upon this. We look at the medical record now, and we see BMI, we see age, and whether you say that someone who's a healthy 70-year-old or an unhealthy 50-year-old, we all know the difference between a healthy 7-year-old playing tennis and an unhealthy 50-year-old who can't make it up a flight of stairs. But the fact of the matter is that you think we're going to get better factors that are going to be able to predict that? Are we going to look at EMR and be able to have an objective measure of frailty? Does it give us a red sign, a red stop sign, a green stop sign? Does it say part of it is adjustable? In other words, they're a yellow light, but you could turn them into a green light. And is this going to be accessible to surgeons? Because I'll just tell you, surgeons are busy enough thinking about how to get through the surgery, and now they've got to sit there and think about complex physiology that may be areas of study that they're not into. So tell us how research in your mind, maybe within the next 5 years, could change how we become better spinal oncologists.
Absolutely. And there are some hospitals who are early starters or adopters of this. So there's a surgical frailty risk score that's being used widely called the Risk Analysis Index, RAI. And in Pennsylvania, for instance, University of Pittsburgh, they incorporated it into the EMR. So any patient, just to your point, automatically with the Epic and EMR, they do get their RAI score. And what they found was the alertness of the RAI allows for patients to then, we as surgeons, we see the RAI, we see someone in clinic, and we're like, okay, we see what the score is. Eventually, once we understand, for instance, a frailty score or a score that we use in the EMR, then that's when the medicine providers, the pulmonologists, the specialties or specialists can then look at what component of the REI is the biggest concern. And then how do we then get them from a frail state? Are there things that we can do to preoperatively get them to a lesser frail state for the surgery? And what it has found is that alertness alone has reduced mortality rates in the whole system. And I think we're shifting into that realm of utilizing some sort of risk score that's easily accessible. But it's not the answer for everything, but it is the first step to standardizing how we're assessing patients in real time.
So you're saying even though we're never really going to have the answer and predict the future, that just the knowledge of and exposure to this is showing some improvements in certain centers.
Yeah, and more deliberate optimization. We send our patients to their primary care, okay, get an EKG, get XYZ. But if the certain risk score shows issues more on the heart side of things or the lungs or other systemic issues, there is a way to really target those in the preoperative standpoint to kind of reverse their frailty a bit as much as possible for them to handle the surgery.
Great. I have one more question before I open it up to Dr. Schwab and to Dr. Mackey if they have questions about what makes an ideal spinal oncology team or person or what have you. But one of the questions is something that I often struggle with as I ask my mentors and then when I mentor people as well is how do we get, do you see a way in which knowledge or pattern recognition. So for example, someone like Dr. Lowe, who says, I've been through this, I have team members, I've created teams, I've worked with teams, and he starts, I'm going to assume, sees patterns that his experience allows him to be efficient and maybe more effective, where you say, I've seen this, I've had this conversation, and it's quick and it's easy, versus someone coming right out of training, or someone like myself who's not right out of training, but might see something new that he's never seen before. Do you think research will make this more accessible to people who may not have it? In other words, what I fear is that we're still going to be in this mode in years where you got to see them all to be able to comment on things versus, no, I'd rather learn or have a smart app or smart tool or artificial intelligence say, this is the knowledge of the crowd, and Dan can have this access sooner, so I don't have to live through multiple mistakes. Do you think research is an opportunity to make patterns and experience more accessible to the inexperienced, or to democratize that stuff toward other people? Any thoughts on that?
No, absolutely. I mean, I think a lot of the research, at least in spinal oncology, are retrospective or via case reports. And I think now there has been a surge in multiple centers creating prospective spinal oncology focused databases. And I think that we're going to learn a lot from those prospective databases. Do I think there's still going to be an element of experience that's going to kind of shape how we focus things, or an institutional way of handling certain pathologies? I think those are still going to be ingrained. But I do think over time, with the advent of AI and with these prospective databases, that now multiple centers are going to be publishing on the same pathology, different, same approaches, different approaches. And then eventually over time with data, AI is going to create a pattern recognition of like, well, this is the best way to treat this pathology. And I do see, I think in the next 5 years, really, you'll be able to really upload an MRI, put some details of the patient, and then based off of all collectively, what's on AI, an output of what the best surgical approach with the best outcome is happening. And you're kind of seeing that in the deformity realm with Metacrea and some other, patient-specific or Unity and so forth, where they'll create these over time collectively or prospectively collecting all these surgeons' outcomes on the patients, reported outcomes, as well as their corrections, to where now you just upload a preoperative x-ray, and then in theory, you're going to end up getting, well, this is the best surgical plan for this patient that yielded the highest patient-reported outcomes. And I do kind of see that happening in the spine oncology realm. It's going to take a little bit more time, but
So before we move on to the other moderators here, Larry, just, I'm hearing from both of you that the ideal spinal oncologist is obviously going to be based on experience, but also on these tools. Maybe in your own mind, either one, tell me what you think the best mix is currently. But in there, I'd love to hear what you think about AI-driven prescriptive tools. In other words, tools that say, Dan, you should do it this way. Maybe I'll use that tool, or maybe I'll say to hell with it, or maybe I'll say, well, in Larry's hands that works, but in Dan's hands that doesn't work, or maybe at my center I don't have that. Any comments on combining the current state of the art with the new AI and research that Aladdin is talking about to make what you think is going to be the ideal for people going to be listening today, who what you think is the ideal spinal oncology team or person or approach?
Right. I think that 100%, I think that the future is essentially leveraging these AI tools as well as these calculators to better inform our decision making. On a day-to-day basis, I think what is the most challenging question that we ask our colleagues, as well we get asked all the time by patients, is how do you think I'll do after surgery, or how do you think how long do I have to live, right? And these are questions that we also bounce out of medical oncology to inform our surgical decision making as well, in terms of are they getting surgery at all, or how robust is our construct? For somebody that's going to live multiple years, we need their construct to be robust, or even a primary tumor, we actually need to get an arthrodesis at some point. Whereas if it's someone that's going to live 6 months, we don't necessarily need to do a long fusion. We just want to make sure that they're pain-free, or whatever we're operating for, it doesn't come back, whether it's a pathological fracture or whatever. And I think that in the current state, without the use of AI, our ability to prognosticate and things of that is quite limited right now. And I think that's probably where the biggest future is. And both Dr. Elsamadises and Dr. Shah are leaders at this in terms of trying to better leverage AI to come up with predictive algorithms to predict things such as prognosis or anticipated surgical risk. And I think that that's where sort of the current state, in terms of based on experience and multidisciplinary collaboration, merges with the future, which is essentially better leveraging these AI tools to help guide this. Because ultimately, I do think that even in the current state, we're limited in terms of how to prognosticate.
Yeah, so at the last couple of minutes here, I'd love to open up to Dr. Schwab and Dr. Mackey for comments or questions.
Yeah, I have a comment and kind of a question. I completely agree that in the future, we're going to be using more AI type algorithms, but I would argue that our problem really is related to data. It's the algorithms as they exist can be quite good at making predictions and helping us, but we are not able to input the data effectively. And just ask yourself, for instance, and it may, spinal oncology, it may be a little bit different, but one of the things that we all talk about in anytime you write a book, you talk there's all this talk about history and physical examination, right? How this is the foundation of medicine and how important it is to, but yet where is that data in these AI algorithms? And so you say, well, it's in the EHR. So before we couldn't get them because we didn't have access to large language models. So now we can get that. We can pull all this data in. But ask yourself, the last time you went through, you were consulted, and you try to go through all the different notes that have been written about a patient, and ask how valuable the history was and how valuable the physical exam was. In my opinion, it's most of it is just copied and pasted. It's really not valuable at all. And in fact, that's going to be feeding many of these models, right? So you'll have a lot of data saying regular rate and rhythm. And what's the AI algorithm going to do with that? Well, it's going to process it, treat it as if it's valid. We all know it's not. Or, how about you're looking at a patient and your neurologic exam? How accurate is the resident's neurologic exam? versus your exam or say the anesthesiologist, whomever. So there's lots of problems with pulling in good data to feed these models. The models have existed, the models are there. It's really our ability to pull data that's meaningful. And this is the quote unquote the art of medicine. But the fact is, this is missing from our ability to pull in data. I don't know if you guys have any comments about that.
No, absolutely. And with all of these, I was just looking at a database recently. It's called the Swiss spine tumor database that they're prospectively collecting. And I was looking at the components that they have there. And to your point, neurological exam is not there. They do have an Asia score for the spinal cord injury aspect, but no, and I think across the board, that's like the integrity of the data of what we're collecting. And that's where I think in theory, the prospectively collected data where you can control what you're entering and what you're implementing and creating these algorithms are going to be very important to create the basis for the larger language models to incorporate into Epic or some other EMRs. But that I think is a struggle across many large database registries and so forth.
I have another question. This is really for Dan, being in a leadership position at a large center. The ARAS protocols for spine. Are you guys? Obviously it's a big deal, and right, the anesthesiologists play a big role in this as well. But how well integrated is that, and how well does it fit with the spine oncology program, in your opinion?
Yeah, I think for everyone who doesn't understand, ARAS is enhanced recovery after surgery, and it's usually a number of different ways that you can impact, from a prehab to an intra-op to a post-op, some objective, some rigorous ways. You say everybody gets this lab, or everybody gets this test, or everybody gets this medicine. And then once you have that, you can then go back and check, did it make a difference? And so what we've seen, just like a lot of other centers, is once you institute some of those best practices, whether it's in the form of ARAS or some kind of other formal way to handle spine patients or spine tumor patients, is you start realizing, you start learning that, there's a huge variance in the way people, or variation in the way that people do things. And why does Dr. Schwab always do it this way? And sometimes they'll say, because it always works. You'll say everyone should do that. And sometimes they'll say, I have no idea why I do that. I didn't even know I did that. So the very fact of looking at it starts to take away some of the variance. And what you don't want is, you don't want necessarily variance to be a problem. Sometimes variance is good. There's two different forms of variation that I think we see in healthcare. One is variance where you can streamline it and it helps things, like asking people to walk after a certain time. Then there's artistic variance, that it's a bespoke, tailor-made thing to the patient. So there's been a number of people saying that variation is good when it's at the highest level of bespoke, patient-centered, but it's bad in other ways, where it has to be make sure everybody gets out of bed and such. So we are looking at this. What we found is that depending on our hospital center, we have different ERAS protocols because they're championed by different leaders at each hospital in their own little hamlet. And so sometimes we push things across the whole system, which we do. And other times we say, we're not going to be big brother, and we're going to let you have your own ERAS protocol. But I do think this will end up being the case for most places. And for people who don't have it, just start it with, we're going to look at things preoperatively, intraoperatively, and postoperatively. And of course, there's things tied to this. Eventually, there'll be tied dollars to this. Because if you can show that this decreases length of stay, hospital administrators will say, keep going. If it doesn't decrease length of stay, they'll say, get back at it. And if it saves implant costs, if you can do things cheaper, or infections, it's going to be a big driver. So for people who don't have ERAS, you're going to have to speak that language because it is seen as an economic driver. So you're always going to have your bosses, your administrative bosses on top of that. But with that, maybe we end on that, given that it's at the half an hour point. And again, our goal today, at least for my goal as a moderator, was to say, what is the current state of the art? And even if it is the current state of the art, where are we going? It sounds like it's a combination of experience and research and technology. And I think we're all going to keep learning. I expect that we're going to be learning even at a faster rate now than ever, given all the tools that we have at our disposal and all the data that's going to be presented. It's going to be a great time of learning, which will help all of our patients. So on behalf of Joe, Mohammed, Dr. Lowe, and Dr. Al-Smadisi, thank you for this half hour. Thank you to Seattle Science Foundation. Thank you to NAS Oncology, and thank you to Icotech. Have a great week.